Nynke.
Thank you very much for inviting me. It's rather daunting speaking to this rather experienced audience, but I'll make a start. And our area of experience is maternal and newborn health, and I think I'm going to use an example of a program that we globally coordinate to maybe take care of some of these questions that we all have. So in maternal and newborn health, I would say that we have been pretty good at identifying the gaps and sometimes even the blind spots. And we have quite a lot of data, and although these are estimated, we would say that maybe it's time to do something about these gaps rather than spend lots more energy in identifying gap after gap, perhaps only in case it is a baseline type of assessment before you start to implement. So it's the rule of 300,000 maternal deaths at least. These are the recorded or estimated ones, 3 million newborn deaths, 3 million stillbirths. And the positive side of this, I suppose, is that they're largely preventable. We know exactly what should be done and to a large degree how this should be done. And we have bundles of interventions. I very much like that term. And we have lots of evidence for each single intervention, for example, active management of the third stage of labor. But we have less information or evidence about what the correct bundle of information or interventions should be. And so there is a line of thinking that we really ought to look at the evidence for what is the best combination. You could argue that this is the wrong question, because if we know what to do, we should look more at how best to do it rather than what's the best combination. But this is also to do with economics. How many interventions can you minimally put in place? There is definitely a gap that we need much more and much more robust data on maternal newborn health and outcomes. I think this has come up throughout the meeting already. And it's always been very interesting for me as an obstetrician with tropical medicine that maternal newborn health is very much seen as the litmus test of a health system. So generally speaking, if the healthcare packages for maternal newborn health work are in place at the health system level, then lots of other things also seem to be functioning. And this is how maternal newborn health has in fact been researched in the past very often. Within the continuum of care, we work particularly on these bundles of care, which overlap. Each are very well defined. We know exactly what they mean, what interventions are included in these packages of care or complex interventions. And one thing we coordinate globally is something we call the Making It Happen program, which is meant to be catalytic. And it is aimed to increase both the availability and the uptake and the quality of these 2 or 3 bundles of care within the health system. And it's been very clear to us from the beginning that these 3 components, as was illustrated earlier this morning, have associations with each other. So availability or not actually determines utilization or uptake or not, and certainly quality does. So they're sort of interrelated. Under the Making It Happen program, we have 3 key packages of interventions. They're all very well defined. They are generic, adapted to the local setting, and delivered at the healthcare facility level. So they are to do with quality improvement, which we largely use what we would call audit methodology, but has all the commonalities of other methodologies discussed here in this meeting. We have always seen training or in-service training with a link to pre-service training, in this case in emergency obstetric care, which is this well-defined package of interventions, as a separate entity. We have never really particularly thought of it as quality improvement, but I guess you could. Monitoring and evaluation is put on this slide as an intervention, because as soon as you start collecting better data and helping people to do so, we see it as both as an intervention and an evaluation methodology. So this program currently runs in 11 countries, and I would say it's very much an example of what you might call implementation research or operations research. I very much appreciate the comment of somebody yesterday who said health systems research is difficult. I would add something in between that, and so what, just get over it and you need to do it. And I think we agree with that, and we are in the middle of doing it. What questions should we then ask? Of course, everybody, all the donors would like us to tell them how many lives have been saved. But we are beginning to learn that it's more important perhaps to look at other things, to say, is there a change at all? And if so, where does this change occur? And this is a type of program that is not an RCT and doesn't have a very clean hypothesis, but has, if you like, a theory of change, a series of assumptions that should this happen, then that, and then that, and then ultimately might lead to something else. So we are beginning to understand that this is very complex data and that perhaps we should look at, is there a change, and at what point in the theory of change model is there a change, which direction is the change, and at what level is any of this perhaps effective, and to what extent. Now, of course, within that you can ask some classical research questions. For example, is it more effective to combine emergency obstetric care training with the QI methodology, or is it enough to just do the emergency obstetric care training? You can combine that. In South Africa, we're doing a step wedge design to say if you do fire drills, which is sort of daily type training, as good as pulling a whole lot of healthcare providers together and training them together in a big workshop. We have then separated out the research component of evaluating the effectiveness of the training with the effectiveness of the quality improvement methodology we use. And it's very interesting. Other people have tried to do this and have said before us, Kirkpatrick is one, that you don't have a single outcome. You have, as you like, if you like, a 5-level framework of evaluation, and here it is. And you need to look at each of these. And each of these gets increasingly complex and is codependent on the previous one. So if healthcare providers don't like the training, they're not actually going to learn anything. And if they don't learn anything, there's not going to be a behavior change. And if there's no behavior change, there's no change in practice, and so on and so forth. So we have applied this framework, and we have some interim data which are not yet public, but it is possible then to measure effect, if you like, at each of these levels, knowing that they are interrelated. And of course, you can then measure case fatality rates and model how many lives you think you have saved. In this case, we anticipate that we have decreased the stillbirth rate by 14% and decreased maternal case fatality rates by 27%, or in X number of healthcare facilities, this number of lives saved. But only because we understand the how, maybe, and those measurements to us are equally, if not more important than the ultimate outcome, which is very measurable. Here is an example of trying to make sense of this complex type of data. In this case, it's the qualitative data about behavior change. And so, there are lots of outcomes, and they're all interrelated. When it comes to improving quality, I think it's a little bit more difficult. There are no existing frameworks to evaluate this. And I think we have to begin by defining what it is we mean by quality, how then do we improve it, and how do we measure quality, if you like. In maternal newborn health, we have been actually very good at measuring what quality is not. And there are lots of slides of how quality is appalling and beyond any type of standard that you might wish to set. However, I think we've recently also agreed on a sort of generic definition of what we would say is quality of care. And this takes into consideration all the things we've discussed. So the treatment must be effective and must be correct, which I think you have just illustrated. We want, of course, desired outcomes, which we can define. And also it has an element of reproductive rights, which happily someone else has already mentioned this morning. So quality is quite complex and can mean different things to different people. We have designed a workshop package based on audits that is very well defined. A lot of these packages are not very well defined. If it's not very well defined, it's also very difficult to evaluate the effect of. So we thought it's important to define that, whatever the content might be.
So, Nynke, can we get through to the questions at the end of this? Is it going to be much? Because I'd like to get to more of the discussion on this.
Yes, I'm trying to, I think, illustrate the questions, but maybe in a roundabout way. We also would like to highlight that audit is something that is a way of asking questions, the why questions. Why do mothers die? Why do mothers die? And that can be extended to perinatal death and to stillbirth. And this is actually a well-tested method that started from the community not far from where I live at the moment in 1935. It's a very interesting article that explains how community and healthcare facility can link up to ask the questions as to why something is not up to the quality that they would like it to be. And this has continued to this day in the UK as sort of the gold standard, where all maternal deaths are audited, all stillbirths, all perinatal deaths, in an anonymous way, and to links also healthcare facility with the national and central level and the community. It's important, I think, to say that the audit cycle is the same generic way of going about things and catalyzing change, as many people before me have explained, and there is quite a lot of evidence to suggest that this works very well. So when we are trying to ask the questions about, what do we measure to assess quality and how do we measure it, I think it's important to say there are new global indicators designed by the WHO with many of us participating in this, but there is currently no single routine type of data measurement in the HMISs in the countries in which we work, and that is a bit of a challenge, and I think that has been highlighted. Again, if you look at the literature, there are many frameworks of multiple indicators that will answer the question, is quality improved, yes or no? We have taken some of these in the current Making It Happen program, and we look at percentage of deaths audited or the percentage adherence to standards which are locally developed and owned and which need to be smart. Have always a mixture of structure, process and outcome, because without structure you can't do the process and you can't expect the outcome. And taking into account the experiences of both those providing the care, who are not always heard as much as those who are receiving the care, or the patients, if you like. So I thank you very much, and I think this is just an illustration of how there are multiple questions you can ask, and that you need to be very clear about what it is you are measuring and how you are trying to answer the questions that we are all interested in answering.
Thank you very much. That was very comprehensive. So next we'll turn hopefully to Edward Kelly. Edward, can you say something so we can see if we can hear you? Can you hear us? He can hear us.
Sorry, we haven't got you yet, Ed. We're not giving up yet, but oh. Okay, we're sending you call-in information so that you can call us. So check your email.
So in the meantime, if I could ask Nynke a quick question about this last one. Is the question of how to measure about this, and this is not really an area for major investment going forward. Surely we can always do more on research, but is this really a big unknown for us?
I don't think it's impossible. I think we're actually doing it in maternal newborn health. I think we need to admit or accept, if you like, that there will be a number of indicators that are relevant to the particular setting or the particular component of care that you are looking at. It's more to try and work out which inputs are the most effective in making the change that you want. I think that is the question.
Does anyone else have a question?
Can I just ask that everybody talk into their microphone loudly?
Any questions while we're waiting for Ed Kelly? Yes, please go.
This is just a question of clarification for Jishnu. Is that on one of the slides you had informal providers, and I was not clear how workers like ASHAs were categorized in formal or informal.
For us, the informal provider is somebody who's in the private sector, charges for care, and may or may not have, and does not have a formal medical degree that allows them to practice allopathic medicine. So an ASHA in the public sector would be a nurse, and if she's actually set up her own clinic and is doing everything, then she becomes an informal provider.
This is a question for Nynke. In our working on maternal and newborn mortality in Latin America, we have noticed that traditionally most of the efforts to improve quality have been addressed to the performance of individual health workers or at the best of the facility where they work. Now, we have noticed that in the case of the main causes of maternal mortality and newborn mortality, the event of the death actually happens many times, not only because of the problems of quality of the individual provider or the facility, but of the movement of the patient from one low level of complexity of care to the upper levels of complexity. For example, that's a case of preeclampsia that ends up needing a C-section, or hemorrhage that ends up needing blood transfusion, or a premature baby that ends up needing more complex care. So what about, could you comment on any efforts on measuring and improving the quality, not of the provider, not of the facility, but of a network that could link different levels of complexity and address in a better way these problems?
Yeah. Thank you for that question. That's very important. There are generally two levels at which this can be done. There are generally two levels at which this can be done. So with the bundles of care called basic and comprehensive emergency obstetric care, they are delivered generally at two levels in the health system, and they are linked. And you can cluster them. So you can say for each facility delivering one bundle of care, there should be 5 referring into that facility for more complicated care. And so when any programs are delivered or interventions, they need to deliver them, not the unit is actually this cluster and not the individual healthcare provider or hospital. And the second level at which this gets done is in fact a confidential inquiry. So a confidential inquiry would pull together all the information on maternal deaths or stillbirths from at least ideally the whole country, but only South Africa has managed to do that. In some countries subnationally, and look at, is there a generic problem with referral from one level to the other, and what is the systematic approach that needs to be taken to take care of this? So if most cases of eclampsia die en route to a higher level, then clearly the referral system needs urgent attention.
Thank you. Do we have Ed now?